Good evening, ladies and gentlemen. First of all, I would like to thank the organizing committee, especially my dear friend, Professor Mohammed Fauzi, for giving me the opportunity to participate in this distinguished conference. I would also like to congratulate them on the huge success, the interesting scientific topics, and the amazing speakers and chairpersons, and the great attendance. It's my pleasure to moderate this vascular imaging and intervention session, and allow me to welcome the distinguished chairpersons, Professor Dr. Mohammed Hosni, Professor of Vascular Surgery in Cairo University, Professor Dr. Ihab Hanna, Professor of Vascular Surgery and the Dean of the Diabetic Institutes. And I would like to thank them all for their precious time and expertise. Let us start this interesting session with our first speaker, Professor Hazem Hamid, Professor of the Radiology and the Head of Cardiovascular Imaging Unit at Cairo University, one of the pioneers in the cardiovascular CT in Egypt. And he will, please, Dr. Hazem.
Good afternoon, everybody. First of all, I would like to express how glad I am to participate in the first edition of this prestigious conference. I would also like to extend my thanks to Dr. Mohammed Fauzi and Dr. Khaled Affas for their kind invitation. Today I'm going to give a short presentation discussing the future of cardiovascular CT and its impact on the field of cardiovascular medicine. Predicting the future is challenging, especially in the rapidly evolving technologically advanced field of clinical cardiovascular medicine. Cardiovascular CT has probably evolved faster than any other imaging technology. The advances of cardiovascular CT can be divided into advances related to the hardware and advances related to the software. We're going to start off by discussing the CT software advances, which are mainly advanced analytical tools, which we then could further divide them into computational flow dynamics and artificial intelligence. Computational flow dynamics are advanced flow and pressure modeling algorithms with multiple applications in the field of cardiovascular imaging. For example, they enable us to detect the vascular stasis within the different cardiac chambers. It could also detect the risk of thrombus formation within the cardiac chambers, and it can also help us detect the critical stenotic lesions, which are a dilemma for the vascular surgeon. As regards artificial intelligence, currently the total amount of data available for analysis is simply too much for the human brain to process. Thus, we usually rely on training, experience, and clinical biases to determine what to focus on as we interpret studies for clinical diagnosis. Artificial intelligence has two main components: machine learning and deep learning and radiomics. With the advent of machine learning and deep learning algorithms and radiomics, there is no longer the need to limit interpretation to simple human analysis. Machine learning is a specific subset of artificial intelligence that is defined by a lack of prior assumptions as to which factors will serve as strong discriminators. It builds pure statistical models, while deep learning is another subset of machine learning which takes these statistical models and structures a multi-layer algorithm so it could create an artificial neural network that we can learn from and make intelligent decisions on its own. Radiomics, on the other hand, is the automatic identification of unique prognostic and diagnostic features in a certain disease. There are four main processes of radiomics, including imaging, segmentation, feature extraction, and analysis. To further elaborate on this, for this diagram, the upper image on the left detects the machine learning process, a stage where we just accumulate all the data we have as pure statistical data, and then we move on to the segmentation phase, whereby this statistical data is grouped into different prognostic and diagnostic discriminators. And then we move on to the deep learning stage, whereby we take all the images and the information from the segmentation phase and put them into a complex artificial multi-layer network, from which then we could move on to allow automatic detection of any abnormality and choice of the best discriminator in any given disease. Now, moving on to the hardware advances in CT. These hardware advances are mainly related to either the X-ray tube, detector, or contrast material. As regards the X-ray tube, the event or the introduction of dual energy CT has made a great impact on the field of CT. It's either tube-based dual energy CT or detector-based dual energy CT. Simply, there are different models to create a dual source energy CT. The first type is when two X-ray tubes or detector systems are set apart at 90 degrees and they rotate simultaneously around the patient. This gives good spectral separation with those low dose, but it has a limited field of view. Another model is the rapid voltage switching dual energy CT, whereby the tube voltage alternates between a low and a high kV value, therefore giving full field of view, but it has the hazard of increased radiation. Another model is the dual spin dual energy CT, in which there's sequential acquisition at different tube voltages. However, it carries the risk of high misregistration. The twin beam dual enhanced CT is another type of dual energy CT, where there is two filters are placed just distal to the X-ray source, one tin and one gold, thus allowing to obtain high and low energy spectrum within the same X-ray exposure. However, it has limited spectral separation. Moving on to the detector-based dual energy CT, the conventional CT, as we know, was based on energy integrating detectors. Currently, there are new detectors evolving called photon counting detectors. This allows material decomposition into color-coded images. To differentiate simply, what's the difference between energy integrating detectors and photon counting detectors? In case of energy integrating detectors, the X-ray photon passes through a scintillator and converting into light photons, and then passes into a light sensor and directly converting into electric signal. In case of photon counting detectors, the X-ray photon passes into a semiconductor to be directly converted into electrical signal. This has great impact on the diagnosis. For example, in this image, there is a latent gadolinium enhancement MRI image on the right and a conventional image on the left. We can clearly see there is a myocardial infarction in the septal wall of the heart. It's not clear on the monochromatic image. However, on the iodine concentration map, it is clearly vivid. Also, it allows us to break down the NECT data into multi-layer and multiple concentration maps. For example, we can inject iodine and gadolinium in the same patient, and we can then filter the iodine map and the gadolinium map on its own, or we can combine them together, giving us higher results and specificity. As regards contrast material advances, dual energy CT and novel nanoparticles, agents such as gold and gadolinium, alone or combination with iodine, enable contrast material to be differentiated from other radiodense materials, thus improving detection in contrast-enhanced scans. Now we're going to discuss the applications of these software and hardware advances on the cardiovascular system. Starting off with coronary artery disease, the main problem in coronary artery disease is easy to detect no stenosis and easy to detect severe stenosis, but what about the moderate stenotic lesions? In case of computational flow dynamics, enables us to perform fractional flow reserve CT, detecting the gradient across any stenotic lesion. If it's below 0.7, it's considered critical, and then it is transferred to the interventional department. In case of myocardial analysis, also, the dual energy CT allowed us to perform CT perfusion. This allows to detect any perfusion defect in the heart. As we can see, there's a tight stenotic lesion at the proximal left main, and it corresponds to an area of ischemia in the septal wall. Its impact on structural heart disease, also computational flow dynamic modeling, allows us to pre-operatively calculate angulation for optimal valve implantation, and also prevents post-procedural outflow obstruction. In case of cerebrovascular diseases such as the carotid arteries, accurate bone subtraction with dual energy CT mitigates venous contamination that is casually present in case of the monochromatic CT, thus improving any underlying stenotic lesion evaluation. Also, the dual energy CT spectral separation allows clear identification of the heart calcified plaques within the large vessels, separating it from the dense contrast material. As we can see the monochromatic image, it's on the right side. It's difficult to separate the calcium calcified plaque from the dense contrast material. However, with the spectral separation and color coding on the left side using dual energy CT, it allows us to clearly identify and separate the patent lumen from the calcification. In case of pulmonary vascular disease, the advent of dual energy CT also allowed us to obtain multiple and different different concentration maps, either iodine map or a monochromatic map or a fused map. What's the meaning of fused? Actually, we can detect the pulmonary blood volume within both lung fields. So what impact does this have? In case of pulmonary embolism, as you can see in these images, which have dual energy CT, and we can also, the color is corresponds to the pulmonary blood volume. In case of a complete pulmonary embolism occlusion, there is a perfusion defect representing the vascular territory supplied by this artery. While in case of an incomplete embolism, as such in this case, there is no associated perfusion defect. So we can say that this is a one-stop shop for pulmonary embolism, giving results of CT angio as well as results of ventilation perfusion scan with great accuracy. In case of peripheral vascular disease, what does the dual energy CT? It has a great impact. For example, it has high, it simplifies bone and calcified plaque removal. Thus, we can clearly and accurately detect any underlying stenotic lesions, which is always has been a difficult question always for any radiologist if they're to measure the degree of stenosis in the presence of dense calcification. Also, it is superior in the infrapopliteal arterial tree. In the subtraction, as we can see, it clearly delineates the arteries below, because we don't only depend on Hounsfield units to separate the bone from the contrast. We can also detect the KV volume and weight of each molecular substrate. Therefore, we can clearly delineate any underlying vascular lesions, not just in preoperative, but also in EVAR cases, in vascular aortic repair. It is very accurate. For example, in this case, the top two images were done by a monochromatic conventional CT, and the two images at the bottom done by a dual energy CT. As we can clearly see, this is the same patient. And the top two images, the graft is placed within the excluded aneurysmal sac, and it is homogeneously enhancing at the arterial phase, and there is no signs of endoleak. However, when we perform dual energy CT for the same patient, we can see that there is clearly a type 2 endoleak, which was not detected in case of the monochromatic, the conventional CT. This is because we can detect low and high KV images and subtract them from each other, and thus we can detect if there is any endoleak accurately. Another example, in this case, also similar case, endovascular repair. We can see there is, with the images that is without contrast, there is dense material within the anterior aspect of the excluded aneurysmal sac. Again, we cannot detect if this is actual leak or if it's part of a thrombosed aneurysm. However, with contrast opacification, we still cannot clearly detect if this is endoleak or not. However, when we perform dual energy CT for the same patient, same case, we can clearly see that there is a posterior type 2 endoleak occurring posterior to the applied graft, and we can confirm that these are actually calcifications and not endoleak from the applied graft. And I would like to hint that this image that is non-contrast, we created retrograde. The patient did not take a non-contrast scan, it takes only contrast scan, and then from these images we can generate a non-contrast scan. We call it virtual non-contrast scan. As regards congenital heart disease, there is also in the future, or in the near future, virtual reality headsets by which the pediatric congenital clinician or the radiological teams can visualize the CT data provided, helping them in assessing pre-procedural planning. Also, the clinical application of virtual reality modeled CT data can be used for virtual stent implantation, giving more accurate results. In case also, the application of 3D printers is a new technique applied. These 3D printers depends solely on the 3D CT data obtained. So when we get accurate CT data from the dual energy CT, we can easily transform it into 3D printer. It gives excellent spatial information for the surgeon or for the interventional radiologist. He can clearly not only 3D image, but he can touch it, and he can see it. For example, this is gain more access in cases of EVAR, instead of just depending on the angles and the measurements we take from the CT or 3D CT. No, we can print it, but to print it, you have to take good CT scan. No good CT scan, the image, the print is not going to be diagnostic. So we have to use these dual energy CT scanners are really, really very nice in presenting accurate information and differentiate from calcification and from the vascular lumen. Thus, we can detect using a 3D printer. I think it's going to come close in the future to perform this as a standard before any procedure. To conclude, the recent software, artificial intelligence, and hardware advances in cardiovascular CT hold immense potential to evaluate almost every aspect of the broad spectrum of cardiovascular disease, with the possibility of guiding treatment decisions for a patient based on an individual basis. So the information, we can personalize it according to each patient. In a nutshell, the conventional CT that's used today is like a black and white TV. With the advent of dual energy CT and later on spectral CT, it is as if we have a color TV. We bring color-coded maps, as I just showed recently in the beginning of the lecture. These color-coded maps, you converted the black TV into a color TV. Not just that, with the advent of artificial intelligence, machine learning, and deep learning, it is a smart TV, because we changed from morphological imaging to functional imaging, which was not available in CT, it was only an MRI. But now, with the advent of the dual spectral CT and AI and artificial intelligence, it's as if you had a black TV, and then you're transformed into not just a color, but a smart TV. Thank you for your attention.
Thank you very much, Dr. Hazem, for this wonderful illustrative lecture. I have a comment, one small comment. You told us that we'll change the radiology from seeing the films to holding and touching the
Not for radiologists, but maybe for the clinicians.
Yeah, for the clinicians, yeah.
But they have to depend on our CT scan.
Thank you very much. Do you have any questions for?
Definitely, and a new one, but I would like to ask if this will minimize the dose of radiation.
Yes.
And the contrast material the patient will be exposed to, because
Radiation? Dr. Hosni is asking about if this advances will reduce the dose of radiation and the contrast, especially the contrast media, because that's the contrast media. Most of the patients are diabetics; they have renal disease, and there's an issue.
Certainly, as I discussed earlier in the presentation, there are different types of scanners, and to detect dual energy CT, some of them are radiation efficient. All of them are radiation efficient actually, but some are more radiation efficient than the conventional scanners. So this is a main concern for all the developers. For the CT scanners, they're competing to reduce the radiation. So this is definitely reduced radiation. According to the contrast material. As I said, for example, I stress on this point that we can take non-contrast image from a contrast image. So the patient he's injected the contrast and he's scanned one time. And then I can take the non-contrast retrospectively. Also, there's new contrast material like gadolinium, which is used in MRI. I can now, it's more safe than the contrast material for CT. I can use it with CT. Before, the gadolinium was not detected by CT, or it was detected very lightly. But now with the dual energy, it can detect it. So it can be as an alternative, alternative to the conventional ionic and non-ionic contrast. So definitely, this is also another case.
And so in patients with renal impairment,
yes, of course,
and had an aneurysm,
yes,
I can ask for this type of CT.
Yes, of course, yes.
So, in your opinion, when this technology will be available for the?
Actually, the dual energy CT is available, but the point is, the artificial intelligence and packages they are developing it.
Yes.
And they're mainly concerned for developing for the heart, for the cardiac imaging, for the coronary arteries. This is the main
issue of.
Yes, the main horse that's leading the race. But then it may be later on.
Applied to vascular.
Yes, there is trials for fractional flow reserve CT and the infraepithelial vessels to detect the critical vessel, but still not many studies are available.
Still a problem in the pedal vessels and the vessels, the foot. Yeah.
Yes, of course.
Still will be a problem.
They are trying it, but still no concrete results available. And as regards the nanoparticle and contrast agents, they are also, I think, about 5 years maximum they're going to be available. Yeah.
Very good. Are there other questions? Thank you, Dr. Hazem.